Hi, everyone who is joining us on Facebook. We are joined by several local physicians and doctors to discuss COVID-19, how it's affected our communities, forms of treatment, and as well as the vaccine, which is on a lot of people's minds right now. So with me right now, we have Dr. Bob Hanson, Dr. Darci Hazelwood, Dr. Megan Woslage. Correct me if I mispronounce anything, and then we will be welcoming Dr. Matt Else here in a moment. We're going to start with our four panelists discussing some topics, and then we are going to jump into a Q&A. So if you have any questions, just put those in the comments or in the chat, and we will keep up to date with that, and we will ask those at the end. Yeah, so I will I believe Darci will be going first. And so I will go ahead and mute and stop my video.
Hi, everyone. Can you hear me? I guess, I don't know. Is that how that works? All right. So, oh gosh. Okay. So I guess I lose everybody. So yeah, hi, I'm Dr. Darci Hazelwood, and I am a physician here in the Tulsa area. I do mainly occupational medicine, and I am out at the American Airlines base, serving the community of maintenance employees that we have here in Tulsa. I just tell you that to give you a little bit of a background. I know we all have different backgrounds here on the panel. Hopefully that's a good thing for different points of view. I do a lot of, we are doing testing currently for only for our population, and we are, we deal a lot with the public health aspect of it, and people returning to work, and the logistics of that. Short, just a description of coronavirus. I may tell you things that you already know. Coronavirus is a virus. We all also know it as COVID-19. As silly as it sounds, some people may not be aware and have asked the questions, you know, the COVID short for coronavirus, and the 19 was from 2019. Boy, let's see how this infection spreads and how it's affected our population. You know, I may ask anybody else if they want to jump in on this as well. I think we all kind of have seen over the last how many months since March, the impact on our population, on everyone, just as an American citizen or people worldwide, and also for our specific populations. Oh, there's Dr. Else. I think he's joining us. We have definitely some specific populations of concern, particularly in our LGBTQ plus community, people of color, immunocompromised positions, age. There's a lot of factors that go into this. Let's see, droplet transmission. So is the biggest way, obviously, that this is spread. It is mainly through our speaking. If you're sick, nasal secretion, sneezing, coughing, those obvious things. But, you know, some things that people also aren't really aware of is speaking, singing, you know, just breathing. There's been many videos that have been out. I don't know if any of you have seen them, that have shown the amount of distance that it takes to spread. The CDC has put out a lot of good information, obviously, for this information, to educate all of us on whatever level you may be on. It's definitely a great resource. You know, they've come up with the close contact being 6 feet, less than 6 feet, for greater than 15 minutes. I'm sure you all have heard. The less than 6 feet was originally thought to be the amount of distance that it needs to be to keep us all safe from each other for the greatest amount of droplet spread. If you're standing and talking to someone, or you're standing, in a store with someone 6 feet away, you're going to be safer. Since the original time, they have come up with that it actually can. They've done studies, that has actually shown that it can spread a lot farther, unfortunately. So while they still have that as the definition of close contact, the recommendations are typically even for larger spaces between individuals. So to minimize that risk. Let's see. Wow, signs and symptoms of infection. Another thing that is, I will admit, a bit all over the place, and we are learning new things every day. The obvious ones, like flu-like symptoms, cough, congestion, fever, shortness of breath, can be one of the scarier things, chest pain. But we have seen many things from sniffly noses and allergies to the extreme ones that I just said, but also the bigger concern right now that I really feel like a lot of people are not aware of is lack of symptoms. Okay, so no fever. We have seen many people without a fever, and not just without a fever, but without any symptoms at all. They don't know that they have it. They're carrying it. We see this in a lot of people. So it's one of the biggest concerns for spread right now, which is why the mitigation recommendations to, socially distance, wear a mask, not gather in large groups, things of that nature. Let's see, where am I going? Dr. Else, do you want to speak to some of the risks? I kind of cut into your part. I apologize because I didn't know if you were going to be able to join us, but some of the different populations and maybe some of the testing like we were talking about.
Sure. Sorry about that. No, I appreciate you taking over my part. I had an unexpected call from a patient, so you covered me on that. So I appreciate that.
No worries.
So my name is Matt Else, and so I'll just kind of go over a lot of what has already been covered with the signs and symptoms. She hit it spot on. The big point that she made was that we don't always see symptoms, and if we do, they're often mild. So I'm constantly having patients coming into the clinic. I work in a family medicine clinic, and they're like, oh, well, this is just, these are my allergies, or I have a sinus infection. I get this the same time every single year. And I keep that in mind, but I also have to keep in mind that this can often be COVID, and more often than not lately, it's been COVID and it hasn't been their traditional sinus infection. Not to say that they're wrong, because I can completely understand why someone would think that, because it feels so much like it, but you have to think that it could also be something else. So definitely keep that in mind, that it could be something that you feel like is something in the past, just like a sinus infection, or nothing at all, which is huge in this next point of testing and testing resources. So you really need to think about when you get tested. Everyone really likes to rush to the idea of testing, and I'm all for testing. I want everyone to have an opportunity to get tested, but we have to test responsibly. So a lot of times we are going into this and we have a new exposure, and we find out pretty quickly that we've been exposed, and we tend to get a little bit panicked and immediately reach out to the closest, ER or urgent care, sometimes your primary doctor, and try to get tested as soon as we can. But we have to be really smart about how we're testing and what test we're using. So there's multiple tests out there. Most of them are swabs, nose swabs or throat swabs. There's some spit tests, and then there's blood tests. So if you do need to go get tested, you really should talk to a healthcare professional about which test you should be getting. If it's early on in your illness, you may not have symptoms at all, or they may be just developing, then your test may not be as accurate. And then it depends on what test you're getting as well. So by having a conversation with a healthcare provider, they're going to be able to talk to you about when you got exposed, when you came into contact. They're going to talk about how many days it's been since then, what day your symptoms started, And they're going to factor all that in and then help you come to the best decision on which test is going to be best for you. So there can be what's called an antigen test. That test looks for little bits and pieces of the virus that can kind of shed off over time. And that's what you hear in the rapid testing. So that can come back within 15 minutes. That sounds great. You know, I would love to have that test. I'd love to know as soon as I can. But there are certain people that should have that test and certain people that don't. So the antigen test is one for people that are actively symptomatic, meaning you're having a lot of symptoms, and it's more accurate if you've had symptoms for a few days. If you just got a headache today, that test may not be too accurate. But if you've been having cough and body aches and all these other symptoms for a couple of days, then the likelihood of that test being positive is more likely. And then we have the PCR test. So that one is, again, a lot of times just a swab. It goes in the back of your throat or back of your nose. It's not comfortable, but it's necessary to get back there because that's where the virus is living. So that PCR test is one that can sometimes take up to a day or more. We saw back in the summer that we got overloaded with testing, and sometimes those tests were taking 7 to 10 days. But that one actually looks for what is the DNA, or actually the RNA of the virus. So the genes of the virus, and can actually be a lot more accurate on the results. The fact that that one takes a little bit longer gives us a little bit more anxiety, but it gives us a bigger testing window of when your symptoms started and how long they've been going on. It's a more accurate. It doesn't have to be a very specific time of when your symptoms are happening. So that test is an excellent one. And then we have the antibody testing. So that one, most of the time is considered what's called an IgG test. That antibody actually doesn't show up for multiple days, 10, 14 days or more after your infection. So a lot of times that means we're looking for a previous infection and not an active infection. So that can help for people that need to go donate plasma to give to people that are actively going through the infection. So those are the different kind of tests. So you really do need to keep in mind when you got exposed, how long you've been having symptoms, if you're having symptoms at all. And then in the future, you have to think of, you know, maybe I had a negative test, but did I get tested too early? And should I really go back to my normal activities just yet? Or should I follow the guidelines of following a 10 or 14 day quarantine based on your healthcare provider's advice? There's a lot that comes into it. And the best option that you can do is talk to a healthcare provider on your specific situation, because they're so complicated. And they will help get the best answer as far as what tests you should get, how long you should stay quarantined, how you can protect others that are in the same household or those that are around you or those that you were around before you had a potential exposure. So there's all that. And then I would say we kind of hit on a little bit the highest risk population. So this is a really hard question to answer, and that there are a lot of high-risk people that are high risk for different reasons. So one of our big populations is HIV population. It's in the name that your immune system is compromised, and we have to do our best to protect you from any type of infection, whether it's COVID, flu, or really anything else like pneumonia, because our immune system just does not respond as well when we have that condition. So that's an obvious one. But you could think of something even as simple as asthma, or someone that's a smoker. These people are also at a higher risk just because of their breathing conditions. So in my eyes, I try not to think of really anybody being more important than others. I think we should be treating everybody like they were a high-risk patient and trying to respect their health by wearing a mask and washing our hands, and just assuming that everybody has a high-risk condition that could lead to them being very, very sick. But if you do have some sort of condition, or you have a question about a condition that you've been diagnosed with and whether or not it could lead to you being at a higher risk for complications of COVID, then again, reach out to one of our resources at the Equality Center and get hooked up with a healthcare provider that can help answer those questions, because we're there for you, and everybody is a unique situation, and we want to make sure you have the best answers for your specific scenario. So that is my little part, and I believe I'm passing it on to Megan, if Megan wants to come along.
Well, thank you, Matt. I think Megan will be joining. I did have a question for you that I think would be good to throw in right here. But when we're talking about like the antibody tests, how long do those antibodies usually stay in your system? How long after infection can you go get tested?
That is a good question. I like that one. So the antibodies, like I kind of hit on, we have different ones. The ones that we're talking to right now are the IgG antibodies. These typically show up about 2 weeks after your infection. There's no, a perfect time frame on that. And as far as we know right now, we're expecting them to stay within your body for about 3 months. Those antibodies are the ones that are supposed to kind of give you a little bit of an immunity to the virus. We don't know if 100% if that's true or how long they last, but typically from what we've been seeing is at least 3 months since your infection that the antibodies could be present in your blood, and then they could potentially wean off or maybe stay a little bit longer.
And so they're present in your system, but not necessarily I think you alluded to this, that it's not necessarily 3 months of immunity, but 3 months of it being present.
We would love that. We don't know the answer for sure. And that's probably the most frustrating thing about this virus is that we want to be a place where we can give you very concise answers and be like, this is what we know. We're still learning that. We're not even I guess we're about a year into this known virus. It was discovered about a year ago. So there's so many things that we haven't been able to come to a conclusive answer on. But we've seen about 3 months of immunity for some people. And then, as you've probably heard on the news, some people are getting reinfected. So we know it's not always the case where there's perfect immunity afterwards.
Well, thank you, Matt. Megan, are you ready to hop on?
Yes, sorry. My name is Megan Woslage. I'm one of the pediatric hospitalists here in Tulsa. I also have a master's degree in public health. From a COVID infection standpoint, I'm kind of on the luckier side of things. In pediatrics, kind of one of the common misconceptions is that kids can't get COVID. So that's definitely not true. Kids can certainly get COVID. If you look at kind of the infection numbers in Oklahoma currently, with the new numbers today, and especially over the past week, they've been climbing quite rapidly. But currently, of the infections in Oklahoma, 12% of them, actually a little over 32,000 of the cases have actually been in the pediatric population. So it's certainly something that can affect kids as well as adults, which we've been seeing kind of more frequently with the increasing incidence more recently. In terms of symptoms, obviously Dr. Hazelwood kind of went over some of these in terms of what we see in adults. Kids, it's very similar. One of the big things that's already been touched upon is that one of our biggest issues with this infection is that they don't have symptoms. So that's certainly become one of the biggest issues, especially in the spread of this infection. But in pediatrics, up to 50% of the cases, kids won't have any symptoms. The most common symptoms that they have for COVID are just the same things of adults. So most commonly you see cough and fever, but certainly we can see GI symptoms, nausea, vomiting, diarrhea. Headache has become a very common symptom, but also muscle aches, fatigue, just kind of normal symptoms you see in any sort of viral infection in pediatrics is also what we're seeing as common symptoms for COVID in this age. In terms of the severity of illness in kids, like I mentioned, obviously we already know that kids don't seem to have as severe of symptoms as adults. Certainly some other comorbid conditions can make symptoms more significant in kids. One of the biggest ones is actually obesity. So that's something that we're seeing kind of most frequently, I think, in the kids who at least get hospitalized for COVID, but also any sort of underlying disability, whether it's cardiac or genetic or neurologic. They certainly can have more significant signs and symptoms related to COVID. In terms of kind of the severe COVID symptoms, obviously respiratory failure, cardiac dysfunction, all of those things are the things that we're seeing in pediatrics. But one of the biggest issues that we're facing is kind of something that's been touched upon a little bit. I think Dr. Ellis brought up kind of these antibody tests. So there's a syndrome called multi-inflammatory system. It's kind of caused by the COVID infection. We're not exactly sure how it works, but basically it's after a child's exposed to COVID, maybe during the current infection, or it may just be after kind of the acute symptoms have resolved, they develop kind of this syndrome that basically causes significant dysfunction in the body. So this would be any kid who has tested positive for COVID, who is positive for the COVID antibody, who has been exposed to COVID within the past 4 weeks, kind of come into the ER, to their PCP with kind of a prolonged fever and some of these similar symptoms, but they have significant systemic effects that affect the heart, the lungs, the kidneys, the blood, that can lead to pretty severe disease in these kids, which has kind of been one of the biggest kind of, I guess, topics in pediatrics, because this was kind of initially discovered in April of this year, and has kind of been increasing in incidence over the past couple of months with the increase in cases of COVID. This is a difficult kind of diagnosis to make because, kind of presents in so many different ways, but we know that it happens in kids who have had current or previous exposure to COVID and kind of come in and can be quite sick. Fortunately, we found just kind of some similar treatments for COVID infection in kids. They've kind of treat the COVID infection in the same way as they've done in adults with this multi-system inflammatory syndrome. We have a few different treatment options, IVIG, so it's an immunoglobulin that we give to kids along with steroids. Obviously, we're watching out for things like respiratory failure and cardiac dysfunction, and we treat those kind of in similar ways that we do to other diseases. But this has become kind of probably the hottest topic in pediatrics, and certainly has led to quite a few admissions throughout the country as well as here in Tulsa, and can make kids quite sick. One of the issues with kids is when they do get sick and hospitalized, a large majority of them end up in the intensive care unit. So kind of just underlines that, yes, kids can get COVID and it can lead to pretty significant disease. In terms of some things that have already been touched upon, it's kind of the same in pediatrics. Obviously, our number one goal is preventing the spread. Certainly, we have tried to come up with things that we can do to treat patients after they are infected. But we're still kind of preaching and talking about, the best way to stop this is to prevent the spread through social distancing, wearing masks. Kids age 2 and up can safely wear a face mask. So those are definitely things that we're promoting in pediatrics. Certainly you've heard a lot about vaccinations recently. I know that Dr. John is going to talk, or excuse me, Dr. Hanson is going to talk a lot about that coming up. But unfortunately for my population, only one of the 2 vaccines that have come out so far, the Pfizer vaccine, can be used in kids age 16 and older. So certainly we are a long way ahead, or excuse me, we have a long way ahead in terms of what we're going to do to kind of combat COVID. And then I'm sure a lot of you have probably recently heard about some of the mutations or variations in COVID infections, specifically coming out of the UK recently. We don't know what the significance of that'll be. The hope is with the type of vaccine, the mRNA vaccination that they've come up with, that if this is something that is kind of resistant to that vaccine, the underlying method for the mRNA vaccines should be able to be altered in a way that we can also cover any sort of new types of the COVID infection. That's really all I have to say about pediatrics, but certainly this is not a disease that is not, clearly we're seeing this in pediatrics and we're seeing long-term effects of this in kids. So certainly something to be aware of.
Thank you, Megan. Yeah, so I will hand it over to Bob.
Hi, so my name is Bob Hanson, and I'm a clinical pharmacologist in pediatrics. And so I wanted to take some time to kind of talk about the therapies that we currently have for coronavirus infections and talk a little bit about prevention measures that are currently coming out. So there's been a long road whenever we think about coronavirus and how we treated it initially. I think a lot of our panelists will remember all of us kind of thinking and reading about the different medications that were coming out. the first one that kind of came out that got a lot of discussion was hydroxychloroquine, which has now been recommended against the use for treatment of coronavirus infections due to increased risk of adverse events that have been associated with it, specifically in cardiac function, as well as lack of efficacy data that actually showed any type of benefit in reduction in mortality or infection rates. And a lot of this is really confusing because there is bench research that has looked at different medications and different things for the treatment of coronavirus, and that's where it gets a little confusing. So right now there's a lot of discussion about ivermectin as well, with some bench research that showed that it potentially may inhibit the viral replication of coronavirus, and that's where the hydroxychloroquine and some of the other therapies have kind of come around. You can do a lot in a controlled environment whenever we're thinking about test tubes and that kind of stuff whenever we're talking about trying to inhibit viral replication. But then you get into this weird phase where when you transition that over into actual humans, that the science doesn't pan out. So we may be able to inhibit viral replication whenever we are working within test tubes, but the doses that are required to achieve that inhibition in a human are just unattainable. And that's why we can't reproduce that in humans whenever we've seen some benefit within the bench research. The other issue is if you are able to reproduce that at those doses, they come with significant side effects. And that's what we mainly saw with hydroxychloroquine, was the dose that you had to provide with that in order, what they initially recommended was producing so many significant adverse events without actually providing any type of protection or safety or efficacy. So that's a lot of the things that are happening whenever we think about the early progression of the disease. Our first big breakthrough came through with a drug called Ramdesovir. So Ramdesovir is an antiviral, and it's a medication that's had a progression of itself as well. Initially, Ramdesovir was kind of a medication that we utilized in a lot of patients with coronavirus infection. As the evidence evolved, we did see that Ramdesovir is best utilized in patients who have moderate COVID or coronavirus infections requiring oxygen therapy. But whenever they progress to that point where they need to get intubated and use mechanical ventilation, we don't see the same benefit that we saw in patients who don't require that with Ramdesovir. The other medication that falls into that category as well is dexamethasone. So dexamethasone is a steroid that very similar to what Dr. Woslage was talking about with the pediatric patients. So it's a steroid that we start in patients that have coronavirus infections that are requiring supplemental oxygen. So it's utilized to help prevent the progression into mechanical intubation, and actually is shown to reduce morbidity and mortality in patients with coronavirus infections. So it's one of our strongest tools in our toolbox against coronavirus infections. And so it's getting utilized pretty regularly as well. So all this brings us to a couple other medications that are out there, specifically to try to prevent you from getting to that hospitalization standpoint. So there are several monoclonal antibodies that have been approved for emergency use authorization. So what emergency use authorization means is that the FDA has said that based off of preliminary data, that there's enough information to show benefit within these medications that we want to try to use them to help prevent any type of disease progression or prevent any type of issues with coronavirus. So specifically, the medications that have been approved are two. One is called bamlanivimab, and it's very difficult to say, and I mess it up every time. And then there's two other monoclonal antibodies that you actually use in conjunction with each other. So I bring these up because the biggest thing that I want to point out is that these medications are approved for outpatient use. So the outpatient use criteria for these medications are actually to prevent hospitalization in patients that are 12 years of age and greater and have a significant risk of progression to severe coronavirus or COVID. So these are largely targeted in the elderly population as well. So that's the biggest use if you're 65 years of age and older and have comorbid conditions that could put you at higher risk. And then in the population of 12 years of age and greater, if you have any comorbid conditions that also put you at risk, those would be indications for potentially utilizing this. I bring this up because this is a medication that is currently being investigated. And if you are in one of those categories and you end up contracting coronavirus, it's worth a discussion with your physician about trying to see if you meet criteria for that use, if that's something that could be beneficial to you. So the next thing I'm going to talk about is the thing that probably is on most people's mind right now, and that's the vaccine. So there's a couple of things I want to bring up. Is the first, there are several vaccines that are currently being studied, and including the ones that have already been released, they are doing ongoing trials and investigations on these just to make sure that they are safe and efficacious. So there's lots of different mechanisms that are being utilized to promote immunity from coronavirus. And the first one that we're going to talk about is the mRNA vaccine, which is the one that's out right now. So mRNA is a technology that's been around for a very long time, and all it is doing is taking a blueprint of what the spike protein on the coronavirus is and inserting it into the cell, and that cell actually replicates the spike protein of coronavirus, of the coronavirus. And so whenever that spike protein is produced by your cell, your immune system actually identifies that as something that should not be there and produces antibodies to inactivate it. And then the nice thing about this is that whenever that occurs, you actually get the benefit of long-term or longer-term immunity, because your memory of your immune system will kick in and say, hey, that spike protein is not supposed to be here. So if it does come around again, I now know what to do and I know how to fight it off. So there's a couple of benefits specifically with the mRNA vaccine compared to historical vaccines. One is that there is no live virus or any part of the virus that is actually in the injection itself. All it is a blueprint for the vaccine or for the coronavirus spike protein. So whenever your body gets the vaccination, all it's getting is just that blueprint that tells the body how to make the spike protein so your immune system can recognize it if it does get exposed to coronavirus later on. The other thing that's kind of interesting about this is that one of the things that happens is there is a significant amount of adverse events that are associated with an immune response being activated. So if you've read anything in the news or read any of these studies that have been released about the two vaccines, you'll notice that there's a good amount of patients who do have adverse events associated with the injection. The most common thing that people do report are injection site reactions. So these are pain at the injection site. So you have a sore arm, there can be some swelling in that area, some redness. So those are the most common things that people do report. In addition to that, there are other adverse events that people are reporting as well. And these are a little bit more significant. So these are headache, fever, chills, muscle ache, joint pains, those types of things. The big thing to note is those are things that we associate with your immune system getting activated. So there's two things to kind of note there. One, if you do get those adverse events, that doesn't mean that you have coronavirus now or the vaccine gave you the coronavirus. It just means that your immune system is being activated to produce antibodies to the spike protein that is getting produced by your body. The other thing is that not everyone reported those adverse events. And so some people did not have those adverse events within the study, but still gained that immunity. So if you're one of those people who get the vaccine and don't have those adverse events, that doesn't mean the vaccine didn't work on you. It just means that sometimes your body handles it a little bit quieter than some other people. So you may not notice those as much. And this was not really described in a certain population more than one of the other. So there is a possibility, regardless of your age or your comorbid conditions, that might be the case. The other thing that we know is that with the mRNA vaccines, they tend to be highly effective. So they report around 95% effectiveness within both of the vaccines. The two that are released right now, the Pfizer vaccine, which is a 2-dose series, 21 days apart, as well as the Mrna Vaccine, which is a 2-dose series, 28 days apart. Both of those have been studied in roughly anywhere from about 13,000 to 15,000 patients. And the safety profile of them has been very, very promising as far as the duration of the trial. Most of the adverse events that were seen within the first few days of the injection and resolved. The other thing to note is there is that second dose that we have to talk about. So that second dose is going to be kind of like a booster if you want to think about it. It's really going to get your immune system going. And because it really gets that immune system going, more people did report more adverse events associated with that second dose compared to the first dose. Again, same adverse events, so fever, chills, headache, muscle pain, joint pain, those types of things. Again, we associate that with the activation of your immune system. And so those are things that we like to see. But again, if you don't, then your immune system may just be a little bit quieter in how it's responding. It doesn't mean that you're not responding, you are still responding, because the efficacy data, again, is there that says it is very effective at mounting that immune response. So those are the two things about the the mRNA vaccines. A couple things that are specific to our population or our community is, the HIV population, like Dr. Els was talking about, they weren't really well represented within the trials. The Pfizer trial only had one patient with HIV. The Moderna trial did have about 80 patients with HIV, and no specific adverse events associated with HIV were reported within the application that they sent to the FDA. The full trial has not yet been released, and so if that does get released, we might try to address that a little bit more. The other thing that's interesting about the Moderna vaccine is that it is a different dose. So it's a little bit larger of a dose, but not much larger. So it is a little bit larger. And with that, more side effects were noted with the Moderna vaccine versus the Pfizer vaccine. Efficacy, again, was the same regardless. And those adverse events, again, were very similar in type and duration, typically about 2 to 3 days with the first dose, up to 3 days with the first dose, and about 2 to 4 days with the second dose. And so it could last a little bit longer with that second dose. Most people have reported just feeling a little off, and some people have felt really, really cruddy. So it's a wide variety, and it's really hard to predict who feels that way and who doesn't. So it's very interesting. The other vaccines that are going to be available, one is an adenovirus vaccine, and that's the one that is currently, the one that's furthest along is the AstraZeneca Oxford one a vaccine. That one uses a different technology, so it uses adenovirus. Adenovirus is a virus that's associated with the common cold, and it uses that particular virus to get uptook into the cell, and then releases mRNA to produce the spike protein, and then you get the same response. There are a couple of inactivated vaccines that are out there. Those tend to be a little bit earlier in the development and pipeline, and so we're not sure when we'll see those. The nice thing about the different types of vaccines and why we continue to progress, even though we have the Pfizer vaccine and the Moderna vaccine, and within the next couple of months, probably the AstraZeneca Oxford vaccine, is because of the different types of storage and handling that's associated with these different vaccines. It's pretty significant, especially with the mRNA ones. But the other thing is that the more vaccine that we have out there and being able to produce on a larger scale, the more likely it is that we'll be able to do widespread vaccination. A couple other things to note about when you're able to get your vaccine, that is described on the Tulsa Health Department website. So you can look up to see what phase you are in. There's 4 phases. But the other thing to kind of note about the vaccine is just because you get the vaccine doesn't mean you're all in the clear as far as mask wearing and social distancing. Those things still need to happen. Whenever we talk about vaccines, the big thing to note is that when you get a vaccine, what you're doing is preparing your immune system to be able to recognize if it does come in contact with that virus, it will know what to do. So in both trials, they did report people who had received at least the second dose of the vaccine and still had a coronavirus infection. Luckily, they did note that people who were infected with coronavirus after receiving the vaccines, their symptoms were much less significant and less severe than those who did not. So neither of the vaccine trials that we have so far reported any type of severe COVID hospitalizations or COVID symptoms with the vaccine group. So that's really promising itself. And that's expected because we know that the whole point of the vaccine is when you get exposed to coronavirus, that your body is ready to go. And then hopefully you will have an adequate immune response so that you don't get sick. So that's why mask wearing is going to be really important and need to continue even though you have been vaccinated, because you could be infected with the coronavirus vaccine and pass it on to someone who isn't able to get the vaccine, especially in these next several months. Dr. Woslage mentioned that the pediatric population, neither one of these vaccines have been approved for patients who are very young. The Pfizer vaccine is the only vaccine that has been approved for patients, pediatric patients, and it's only to 16 years of age and older. So you have to be at least 16 in order to receive it. The Moderna vaccine is only approved for patients who are 18 years of age and older. The other vaccines, we don't know what how low in age they went down because they haven't released any of that data yet, but that's something we'll be looking at as well. So there's a huge population in the United States that's going to need to be protected, and we do that protection through masking and social distancing and continuing that until we have enough people vaccinated that community spread of the virus is no longer something we have to worry about. And I am Happy to answer any questions you guys have. I'm going to throw it back to Alex to see if there's anything else that he wants us to talk about. With the vaccines, I know you had a couple of questions that you had already kind of had people asking about with the different things.
Yeah, we've had a couple questions in chat. I think specifically, this is the most recent to what you were talking about. And I appreciate you mentioning, you know, our patient or our community members who are HIV positive and kind of those, how they were included in those studies. I did have somebody who was asking about potential drug interactions with either with PrEP, other members of our community, possibly, you know, taking hormones or blockers or anything like that. Has there been signs of drug interactions so far?
That's a great question. And so whenever we think about drug interactions, we generally think about activation of enzymes or inhibition of enzymes, and that's where we get the majority of drug interactions. And this is a huge thing in the patients with HIV with their medications, or patients who are on PrEP with their medications, because a lot of those medications have significant roles with enzymes. We can safely say that the vaccines have no activation or inhibition of any type of enzymes and should not affect HIV therapy or PrEP therapy or HRT therapy. Obviously, we don't actually have studies to say yes or no, but we do have pharmacology data that suggests that there's no inhibition or activation of any type of enzymes. So we should not have to worry about that.
Thank you. Similarly, I have also had some folks ask if there are any like allergic reactions. I know some folks who are like allergic to eggs can't get the flu shot or have adverse reactions. Is there anything similar that we've seen with the COVID vaccine?
Yeah, so we have seen some anaphylaxis with the COVID vaccine itself. And just to kind of take a look at a couple of things with that question. One, the Infectious Disease Society of America and the CDC and the WHO have walked back any recommendations about avoiding the flu shot whenever you have an egg allergy, because the amount of eggs that is in the flu shot is so minimal that it is not a concern. And the safety that you get with the influenza vaccine is outweighs any type of risk with the influenza vaccine. So they walked back that recommendation and now are recommending that even if you have an egg allergy, that you do get the influenza vaccine. With the COVID vaccine, there have been several high-profile reports of anaphylaxis. I believe we're up to 6 now within the United States, and last I heard 3 in the UK, but I haven't been keeping up with the UK data as much, so there could be more. And those are to be expected. There are a couple of excipients, which is the word we use for different things that keep the vaccine stable, that are in the vaccine that could cause an allergic type reaction. So whenever we think about what's in the vaccine, there is a lipid particle that has really advanced the utilization of mRNA vaccines, because that lipid particle actually provides protection from degradation of the mRNA strand from enzymes, as well as increases the stability of it. But then there's other stuff in it, like in the Pfizer vaccine, there's something called polyethylene glycol, which is a very common excipient that we utilize in tons of injectable medications, as well as some sodium salts and potassium salts and some sugar. So a lot of what's being discussed, is it the lipid particle or is it that polyethylene glycol that's causing the anaphylaxis? So they're still doing a lot of investigation. We're not going to know until we have a better idea of what those anaphylaxis reactions were attributed to, and that could take a while. Right now, the recommendations are that the benefit that you get from the vaccine is so great that you should go ahead and get it, even if you have a history of allergies, but it should be done within a healthcare facility, and you should monitor yourself at that healthcare facility for at least 30 minutes.
Thank you. Yeah, that's very insightful, and I'm sure will help a lot of people to hearing that. I did have one specific question come up in our chat, and it specifically asks, is the vaccine safe for someone with COPD?
Yes, and it's even more important for someone with COPD to take the vaccine, just due to having COPD puts you at extremely high risk of an increased risk of severe COVID infection. And so I'm sure one of the other doctors, if they want to jump in, they're more than welcome to. But I would say you should definitely get it.
Somebody did add a follow-up, and again, anybody can jump in on this, but it was just saying, could you say the same of the steroid that is being used for treatment of COVID? And I believe it's in response to the COPD question as well.
I may throw that to one of the other physicians that are on here. I don't know if Dr. Woslage or Hazelwood or else has any thoughts on that. I guess the question would be, is dexamethasone or the steroid to treat COVID safe for patients with COPD?
Hey, this is Dr. Else. All right, so that's a tricky question. If the person that's asking it is probably asking it for a reason, oftentimes we use that steroid for people that have an exacerbation of COPD, meaning their COPD symptoms have gotten worse. So I hate using this answer, but it's going to be important to talk with your provider on this one, because oftentimes when we give a steroid, what it's actually doing is it's knocking down the immune system's response to what's going on. The immune system is sometimes overreacting. And so we use that steroid so that you can breathe a little bit better. It opens up your lungs. But at the same time, that's giving you susceptibility to other infections at the same time. So from what I'm understanding in the hospital, they are using that when the symptoms are so severe that the COVID is getting so severe that they are just trying to shut down the floodgates from just opening up in the body, and they're using that steroid to really try to get the symptoms to calm down. So that in that case, the infection's already there, and they're trying to get the body to stop overreacting. So when we're talking about giving somebody with COPD a steroid on an outpatient setting, meaning they're not in the hospital, they don't have COVID, or they're in the early stages of COVID, it's a different scenario. And it's really something that you should discuss with your doctor, because not everybody is a candidate for steroids. Even though in the past, all these past winters, we'll throw them at you like it's candy to try to help keep you out of the hospital. But in this case, there's a new variable in the equation, and we can't really just be giving steroids to everybody. But there are specific scenarios when they are appropriate, but it's not always the first answer like it is in the past.
Thank you, Dr. Els. So I have a couple more questions from our comments and chats. I will also say, if I misconstrue anyone's comments or I misread it, just let me know. Just type out a comment and clarify if anything gets confused. But we have somebody who's asking, I believe, about the distribution list. And I believe you said that could be found on the health department. Once you know what phase you're in, or what group you're in, would you go to your primary care provider to work on getting that vaccination, or is there a specific place that you're needing to go?
So right now I would, the distribution phase is a little bit complicated because there's lots of different moving parts. The first part is supply. So we are currently waiting on supply of the vaccine to meet the demand. And so with the healthcare workers being first in line for the vaccine, especially our frontline healthcare workers who are working on COVID units and stuff, there's a pretty high demand for it. So that should also give you a little bit more confidence in the vaccine as well. If a lot of healthcare workers are very excited about it. I was lucky enough to be part of that first day of vaccination at the hospital that I work at. It. I will tell you, the stories that I heard were just harrowing, and they were just very grateful. So there's a lot of demand for the vaccine. With that demand comes the issue of supply. And so we're currently working on that. With the approval of the Mrna vaccine last week, that will hopefully help supply. And my understanding is that a lot of the Mrna vaccine did go out today. We were currently looking at probably sometime in January, February, or before we move to phase 2, which is outpatient healthcare facilities and some other high-risk individuals within that phase. So it's a little bit hard to identify when those different phases will happen, because it's all going to be supply-based. once that does happen, the health department is going to be our big coordinator for this. And the reason the health department is the big coordinator for this is because this is all approved under that emergency use authorization. So this is all being directed through the government and through local governments to help make sure that it's a coordinated effort where everyone is getting the vaccine according to the phase that they are in. So it will be something that is released by the health department of the distribution plan for different clinics and how they get in contact with them. It also depends on what type of vaccines that we have available at the different phases. So right now we have the 2 mRNA ones, which do need to be kept very cold, and storage is a little bit more concerning for one versus the other. So the Pfizer vaccine has to be kept very, very cold. The Mrna vaccine has to be kept cold, but not as cold. And so that is inhibiting where we're able to actually stage the vaccine out in the community as well. So more answers to come once we get a little bit further along in the process. But the Tulsa Health Department, they have a great COVID-19 vaccine page that gives you a lot of great information.
Thank you. That definitely clarifies things. I know we're still very early in this process and these vaccinations are incredibly new. We did have one question, and again, because this is so new, you may not know the answers to this, and there's a lot to be discovered, but they were specifically asking if we believe that this vaccine is going to be similar to the flu shot where you have to get it every year, or will you need boosters? I know you need that initial booster or the booster like you referenced, but how is that looking right now?
So I'm going to sound a little bit like a broken record, but the answer is we don't know. So the current recommendations for the flu vaccine, if we can talk about that for just a second to kind of compare it. The flu vaccine, the recommendations change, and you have to get a yearly one because there is variants of the flu that variations and mutations of the flu virus that happen every year. And so you end up having to get a new vaccine because of that. The other issue with the COVID-19 vaccine is we are still doing research on it. So those trials that were released in October and November, the phase 3 trials that were completed in October and November, they're still ongoing, and they're still collecting data from those individuals who participate in that to identify how long the antibody response is occurring. So we don't know the answer to that yet. We will know the answer hopefully soon. And it also will depend on how many people get vaccinated. If we were able to get everyone vaccinated in a short time frame, then we could do what we've done with several other diseases within the human time frame of getting rid of it completely. And so there is no more coronavirus out there. Unfortunately, I think more likely what's going to be the case is there's going to be several people who don't get the vaccine. And then that's going to continue the spread of coronavirus within communities, which will make a vaccine potentially necessary on a regular basis. But again, we don't know how long the immunity you get from the vaccine is going to last. We hopefully will have that information by next fall, winter. We'll know at that point in time if we do need to re-up. And so that will be the other thing to kind of keep in mind.
Thank you, Dr. Hanson. Yeah, there's a lot of things. Yeah, you don't sound like a broken record. Like there's a lot of stuff that we don't know. And sometimes that's the only thing we can tell people. So for anybody on the live stream, if there were any questions that we missed, please put those in the chat again. There were a couple that went away after a certain time period, but I believe we've covered most of the questions so far. Are there any final words that you want to leave people with? Any recommendations that you have?
There's a light at the end of the tunnel, and we can see that light. It's a very exciting couple of weeks of being able to provide some hope in this fight against coronavirus. And so just hang on there, keep wearing a mask, keep social distancing. The public health officials will let you know when you can stop, and just kind of hang in there and stay healthy.
I just want to second that. You know, I was supposed to mention this earlier in my discussion, but I can't stress enough how important the recommendations are from whether it's all of us. Obviously, we believe in it or we wouldn't be on this call. and the public health officials, you know, whether it's just the simple washing of the hands or social distancing, but mask wearing. Most everyone that knows me knows I'm a huge proponent for mask wearing. We have been wearing masks for decades, if not centuries, in medicine, and wearing them to prevent the spread of disease. This is not new to coronavirus. It's a proven fact. I mean, we've been wearing them, and probably honestly, even in our community, not enough. We look at other countries and how they have utilized them. They've done a lot better with the prevention of some diseases because of that. So, I mean, it's kind of just a simple fact. Think about it. Keep your, you know, respiratory droplets and your germs to yourself. Protect other people, whether it's your family. Figure out your why, whether it's your kids, your parents, your, you know, best friend, you know, someone you know that's high risk, whatever. But you know, do it for yourself if you can, but if you can't, you know, do it for those that you love. So stay safe out there. Keep yourself and your loved ones protected, and try to have a happy holiday.
Well, thank you, Darci. Does anybody else have anything they would like to add? Well, we have several people who are saying thank you in our chat. Just thank you for your time and all the information and being willing to speak on all of this. Again, I know that there's a lot of unknowns and a lot to come. So we're just, we will wait and see what things have to, or what things come up next. But everybody, like Darci said, keep wearing your masks, stay safe. If you need help finding any information, feel free to call the center and we'll get you connected to where you need to go. But otherwise, everybody have a great night. And like Darci said, have a happy holiday.